Good morning, everyone. I'd like to thank you all for attending this morning. I also like to thank those people who are tuning in on the auditory and the visual media. They really are interested. Sometimes they can't make it here, but there are a lot of people across the Commonwealth, and in fact, a lot of people who are outside the Commonwealth who are interested in the business that we are doing this morning. It looks like we do have a quorum, so if I could, I'd have the secretary please call the roll.
Senator Berg, Senator Givens, Senator Meredith, present. Senator Schickel, Senator Burke, or Representative Burke.
Thank you for the promotion.
Sorry.
Present.
Representative Elliott, Representative Proctor, Representative Whitten, Co-Chair Weber,
here.
Chairman Douglas.
Present. Thank you so very much. We
Oh, we don't right now. Senator Givens was out in the hallway, wasn't he? We can
yeah.
come back to minutes. We
Does
can
that
come
mean?
back to the minutes.
Okay. We do have a quorum, but they're not all inside the room, so we'll come back. we'll come back to the minutes. I really want to make sure that I'm honest with everyone. As those of you who will be testifying this morning may or may not be aware, in front of my committees, I don't like abbreviations. Part of our job here in the committees that we have here in the Commonwealth is to help educate and help to inform our constituents. And it really is important to me that they understand what it is that we're doing to serve them and to do the people's business. So I would ask you to always, when you make a presentation, fully say out the words. Part of my philosophy is if you have to use a bunch of abbreviations, you may not know what you're talking about. So I don't mean to offend anyone when I say that, but I simply, but I truly mean that. Okay. We now have a quorum. Okay. We need to approve minutes from our previous meeting. We have a motion. And do I hear a second? The minutes are approved from the last meeting. Do we have anyone who has any introductions this morning? Senator Gibbons.
Mr. Chairman, thank you. And it is truly a great honor to introduce a former colleague and a close friend of mine, and I'm going to purposely embarrass her. Life rarely gives you these opportunities. So I come in as a freshman legislator in 2009. And unlike the freshman legislators today who are all so skilled and so passionate and able to hit the ground running, I was scared to death. And I met this person named Katie Stein, and she frightened me even more. I didn't know I could be more frightened than I was. And so realizing that I was going to have the chance today to do an introduction and express my appreciation to her for shepherding a young legislator through so many twists and turns and turmoil, Senator Schickel and I came in together. Senator Schickel, I'm introducing our colleague, still friend, Katie Stein, and sharing some stories. So when I finish, you may have some stories you want to add to it. But knowing she was going to be here today, I did some quick research, and my staff ably found some pictures. And here we have a picture of Senator Stein informing the entire Northern Kentucky caucus exactly the way that they were supposed to act on this agenda item. And so, Senator Stein, I've got this for you afterwards. In addition, though, not only do I have this one of her informing the entire Northern Kentucky caucus about what to do, it appears that Damon Thayer needed a little extra attention on the question. And so we have her telling Damon Thayer in individual, purposeful, directed language how he needed to conduct himself on this issue. I say all that in humor to express my appreciation and sincere admiration for her leadership, her passion for so many issues, and her friendship. Thank you, friend. Thank you, Chairman.
Thank you, Senator Gibbons. And did you have a follow-up?
Yes, I do, Mr. Chairman. First of all, I just want to say ditto to everything our President Pro Tem has said, and it is good to see her here. She doesn't come to visit us very often, and she, Mr. President, just like she always had, on the way down, she was texting me everything I was supposed to say at this committee meeting, and she told me I wasn't allowed to say anything except what was in those texts. So I have my script all ready for me. I'm ready to go, Madam President. Thank you.
Co-Chair Weber has someone he'd like to introduce.
Mr. Chairman and members of the task force, we do have a number of people here today from the Kentucky Home Birth Coalition, and I want folks welcome here today. I would also like to echo what has previously been said and welcome Senator Stein back. I had the opportunity to serve with her early in my tenure here. And Senator, I will say that you have had some truly great senators follow you from Campbell County.
Thank you so very much. With that being said, we're going to start some of the testimony here. I would ask the first group of presenters to step up. Representative Proctor, and if you would introduce those with you.
Good morning. I just want to start off, first of all, thanking the co-chairs, Senator Douglas and Representative Weber, for the opportunity to present today. I want to introduce our guests really quickly. I'll have them introduce themselves, and then we'll come back.
Oh, hi, I'm Dr. Mark Schroer. I practice internal medicine in Newport, Kentucky.
Hi, my name is Carol Dwyer. I'm a registered nurse from Northern Kentucky as well.
Well, welcome. We really look forward to hearing what you have to say this morning. But before we begin, will you please raise your right hand? Do you solemnly swear to tell the whole truth and nothing but the truth?
I do.
I do.
Thank you very much. The floor is yours.
Thank you. I am Representative Mary Ann Proctor. I represent the 60th District, which is part of Boone County. I'm really excited to be here today to be able to testify and just kind of talk about why we're bringing the certificate of need. In the last several meetings, we've heard a lot from organizations that benefit from certificate of need. Today, I thought it would be interesting perspective from a legislator and also from those who are on our front lines, our physicians and nurses, about their experiences with certificate of need. So for me, why is this been brought up? Well, as a new legislator, I did a lot of campaigning, and this was definitely one of the top things I heard when I was out at the doors. My job as a legislator is to represent the voice of the people, and the people are crying out to have healthcare options, which we don't really have in Northern Kentucky for sure. The other reason that we're bringing this, we have 50 years of data now on certificate of need, and we can see it is not meeting its intended goals, which is accessibility, affordability, and quality. I'm not going to speak to quality today. It's not my job to rate any hospital on the level of care they're doing. That's for another organization. That's not me. But I want to talk about what the data is saying. The data is so strong that we have at the federal level, we have federal agencies, including the Federal Trade Commission, the Department of Justice, Department of Health and Human Services, Department of Labor, Department of Treasury, all support the Certificate of Need repeal. The Federal Trade Commission and the Department of Justice have both submitted testimony in support of Certificate of Need repeal across both Republican and Democrat administrations. This is not a red-blue issue. This is a health care issue. Another reason that I want to bring this up is cost. And I think this is certainly one of the most important things that the Certificate of Need is not achieving on the goal. If you will look last session or after last month, you all were emailed the Striving for Care. It's in your packet today. I would really encourage you to look through it. I think it answers a lot of the questions that you guys have, certainly with data particular to Kentucky. So in here in Kentucky, this is this is us. This is our data. It's a comprehensive study with full citations and descriptions of every study done in Kentucky. So that's the striving for better care. And I think you'll find that helpful. Another thing that you may have gotten, those of us on the task force, we were all emailed after the meeting, don't blame Medicare for rising medical bills, blame monopolies. It's a fantastic read. And again, I think you would find it very informative. So what they're finding in there, the researchers at RAND report that prices paid by private payers for hospital care are nearly 2.5 times, on average, the prices paid by Medicare for the same treatments at the same hospital. Why does that matter? Because we're crushing our middle class. If you look at the Millman Medical Index, the cost of healthcare consumed by a typical middle-class family of 4, with a typical employee-sponsored preferred provider organization, or PPO, sorry, Dr. Douglas, on that, but people know what that is. It costs $30,260 in 2022. It's a burden on the middle-class families that's rising faster than their ability to pay it, increasing by nearly $9,000 for the typical family of 4 between 2010 and 2018, and by another $5,000 in just the past 2 years. You know, here in the House, this task force on CON, it's been stated that we need a monopoly to protect our rural hospitals. But inflating costs for privately insured patients by limiting competition isn't the right way to ensure that patients in rural areas maintain access to health care. In fact, hospitals and facilities are closing throughout our state now. We've had 4 that have closed since 2005, and that is with certificate of need laws in place. It's clearly not meeting the goal. It also hurts rural hospitals, which has been one of the big complaints, but it leaves rural hospitals with less beds, but certificate of need by design is designed to restrict the number of beds. So when we have situations like COVID and we have a rapid increase in need for beds, it limits the amount of beds that the rural hospitals can do too, as well as the services. They can't do the beds, facilities, and the capital investments without going through the long, substantial review to increase those and be responsive. So I'm not sure that CON is really helping our rural hospitals. Contrast to our urban areas where there is a monopoly, according to the Fitch ratings, there's a number of strong competitors, and I'm speaking of Northern Kentucky, where I represent. There's a lot of strong competitors in the broader Cincinnati, Northern Kentucky area. Although I'm a Kentuckian, as are my constituents. So to go to Cincinnati for our healthcare choices often isn't an option. Certainly if your healthcare doesn't transfer across state lines, or if it makes it more expensive for you because you're out of network. So, but the Fitch report says that the established provider inpatient position in Northern Kentucky's primary service area is generally protected by Kentucky's certificate of need laws that restrict new acute care market entrants. So we're seeing over and over, certificate of need is protecting our hospitals, but is it protecting the patient? Is it giving them choices? Is it controlling cost? And the data is saying no. So in the accessibility, urban physicians and case managers tell me they often don't have a place to discharge their patients once they leave the ER or they're leaving the hospital. So they may be staying unnecessarily longer in the hospital, costing them and the state money to keep them. In 2013, after the Affordable Care Act was introduced, the Commonwealth was commissioned the Healthcare Facility Capacity Report to determine whether Kentucky has an appropriate level of healthcare facilities and health services. The capacity report had a particular concern back then in 2013 about mental health facilities. Their recommendations, including eliminating certificate of need requirements for ambulatory surgical centers, home health agencies, and imaging services like MRIs and PET scans. It found that the certificate of need laws were leading to harm. Some examples were our ambulatory surgical centers were operating above capacity, and home health agencies were not being allowed to open up in counties where they were desperately needed. The General Assembly didn't act in 2013. Here we are 10 years later, certificate of need requirements for these services remain. We have a growing population and an aging population. Kentucky needs the tools to expand access to the healthcare facilities and services now so that we can serve our baby boomers and beyond. We need more nursing home beds. We need more home health, more surgery centers for things such as joint replacements. We need more hospital beds. We need lots of stuff. And we need nursing homes to serve this population. Also, with the rise of mental health, we can't deny that this is an issue. We're running out of facilities, and mental health is still restricted by certificate of need. We are unable to treat our citizens as we need to. When you have one system, where do you go when the beds are full? When you have wait times to see physicians that are months, where do you go? Where do you go to get a second opinion? Where do you go as an employee for better pay, for career advancement, or maybe you don't want the option of working at one place? Where do you go if you are limited by a non-compete clause? Certificate of need limits all of those options. So what would it look like if Kentucky didn't have certificate of need? I would say look no further than our neighbors to the north. Look at Indiana. In 1999, repealed certificate of need for everything except long-term care facilities. Ohio, 2012, repealed certificate of need for everything except long-term care facilities. Our neighbor to the south in Tennessee, they did a major certificate of need overhaul in 2021, certainly in response to COVID. States around the country are realizing that certificate of need laws are hurting their constituents. This last session, South Carolina passed nearly full certificate of need repeal, except for long-term care facilities. States that have tackled major certificate of need reform in the past few years include Florida, 2019, Montana, 2021, West Virginia, 2023, North Carolina, 2023, Connecticut, 2023. I believe the time has come for Kentucky to overhaul our own certificate of need laws to allow our people more healthcare options, more accessibility, and affordability. Also believe we need to hear from the people who are on the front lines, who are impacted every day by the certificate of need laws. So with that, I'm going to pass off to Dr. Shore.
Thank you so very much, Representative Proctor. But I also want to remind the other two presenters that we have. We have others who really are going to want to speak today. So I'm going to be generous and give each of you 6 minutes, or one of you 12 minutes. And
Wow.
we'll be on the clock. Thank you very much.
We better get started. Good morning, everyone. I'm Dr. Mark Schroer. I practice internal medicine in Northern Kentucky. I went to the best medical school in the world, located in Louisville. I was a full professor or assistant professor at the University of Cincinnati. I've practiced everywhere from the Crow Indian Reservation in Montana to Addenbrooke's Hospital in Cambridge, England. I rotated through the Highlands Regional Hospital in Prestonsburg as a student. I made my first foray into healthcare policy at the age of 16 when I went with my father to Senator Wendell Ford's office in Washington, D.C. Now today I'm really here to ask for your help. I need your help. I think we can all agree that we can do a better job in Kentucky in providing health care. You've all seen the statistics. I don't need to rehash them. But we spend a lot of money, and we still have some of the unhealthiest people or patients in the nation. We all need to do a better job. Doctors, pharmacists, legislators, insurance companies, educators. We all need to do a better job, because the issues that this encompass, that Representative Proctor has mentioned, quality, access, cost, equity, labor, will not go away. And statutes that do not further these 5 principles need to be revoked. And the certificate of need is one of those. Why? Because the certificate of need has created a whole host of unintended consequences, and it has not achieved its mission. What does it say? It's going to improve quality, increase access, and regulate health system expenditures. Now, anyone who thinks that we have achieved that simply is not involved in patient care. I have a perfect example of a patient of mine by the name of Nick, and yes, I have his written permission to discuss his case. But a few years ago, Nick needed an echocardiogram. which is an ultrasound of the heart, because he has heart failure. Well, he couldn't get it because he said to me, Dr. Schroer, I can't afford it. Because there's only one place where he can get that echocardiogram. He had no other choice. Now, fortunately, he's still with us today, but this problem is a problem that I face with my patients all the time. The certificate of need, what it has done is it has achieved consolidation. Some would call it a monopoly. And people think, well, maybe this is a good thing. But in the packet that I've given you, there's a lovely article from the New England Journal of Medicine, very statistically rigorous, that states that consolidation has not helped control costs, and it has not helped with the quality of care in the United States. So I also would like to bring up that the certificate of need is a labor issue. This is also a labor issue. The hospital where I live and work owns most of the physicians. And I think we all need to ask ourselves, do these workers have rights? And I think every worker has rights. So will these workers have due process if they have a dispute with their employer? And who's overlooking that due process? The other thing I would mention is, and I've also been a victim of this, is the non-compete clause. If you go work for some company as a physician, you can't open up a shop next door or across the street. You have to wait a year, sometimes 2 years. So what does that mean? Well, I'll tell you what I did. I went to Ohio. But where's my heart? Kentucky. So I left and I came back and I opened up my own shop. But for 2 years, or really 4 years, I was over in Ohio practicing medicine when I could have been serving my friends, my families, and my neighbors. I think we need data-driven policy. Data-driven policy. What do the experts say about the certificate of need? What does the New England Journal of Medicine say? What does the Journal of the American Medical Association say? What does the Federal Trade Commission say? What does the American Legislative Exchange Council say? The CON, the certificate of need, is detrimental to the provision of medical care. The KMA, the leading organization of physicians in this Commonwealth, passed a resolution at its annual session in 2021 supporting the modification or elimination of the certificate of need. How do all these different groups come to the same conclusion? Data, metrics. The certificate of need debate highlights the need for data-driven health policy. And we have lots of it. There's a study that I have given you, again, in the Journal of the American Medical Association by Dr. Hughes and others, and it looked at states with the certificate of need and without the certificate of need. What did they conclude? And I quote, "There were no significant differences in markers of hospital volume or quality between states without versus with certificate of need laws." End quote. The study affirms what so many of the other studies have independently concluded. So whether it is the New England Journal or the Wall Street Journal, they all say the same thing. It's time for the certificate of need to go, as it is not performing its functions.
Excuse me. Ms. Dwyer.
Thank you.
Are you yielding some of your time to him, or would you like to proceed with yours?
He can finish up if he needs to finish up.
Yeah, I mean,
Okay.
I
that's fine.
thank you.
I just wanted to make sure I'm being fair to everyone.
Okay.
I apologize for interrupting.
No, thank you,
I just wanted
Senator
to make
Douglas.
sure. Okay. Proceed.
As a physician, I know you would be very polite. Yes. Many are concerned that the rural hospitals will close if we repeal the CON. The real question we must ask ourselves is, how do we deliver medical care to the rural regions of the state? And I want to just back up for 1 minute. You know what? The whole system needs to be revamped. The whole system the healthcare system needs to be revamped. The certificate of need is just one of many issues of healthcare that need to be fixed here in this state. From education, pre-medical, medical, postgraduate, hospital care, home care, the whole. So this is just the beginning, and I hope it's a road that we can all go down together. But how do we deliver quality medical care to rural regions of our state? That is the real question. The question is not how do we keep the hospital alive, how do we keep the patient alive? If I cut my leg with a chainsaw on my farm in Grants Lick, Kentucky, my odds of survival are nil. I'm 35 minutes away from the emergency room. There is no freestanding emergency room to serve southern Campbell County or northern Pendleton County. But that's the real need. And that is an idea that we should be talking about in Kentucky, because medical emergencies and providing chronic care are the challenges for those who live in isolated regions of the state. Some rural hospitals find it difficult to stay open. I agree. But the problems they have are multiple and will not be solved by one action. The CON is in place now, and rural hospitals are in trouble. The CON has not solved staffing problems, malpractice, administrative burden, poor infrastructure, or reimbursement.
Hey, it's your turn.
I will close and thank you. I agree with the representatives from St. Elizabeth's that say, you know, the Supreme Court has ruled that this is proper. Where I disagree is that we have this law on the books. So I say to you, as Justice Ruth Bader Ginsburg said in a dissent,
Excuse me, I'm gonna
the
have
ball
to
is in your
interrupt you.
court, Congress.
And I apologize. But,
Thank you.
But we do have a limited amount of time for all our presenters, and I do want to thank you for all the words that you've given us. But we do need to move on, Ms. Dwyer.
Hi.
I will be polite and give you 6 minutes.
Thank you. I'm Carol Dwyer. I'm a registered nurse. Been a nurse for well over 35 years. And I'm a Kentucky girl, born and raised. And when I was growing up, there were several different hospitals in northern Kentucky. And when I graduated from nursing school, that was a great benefit to me because I could go from one hospital to the other. It could benefit me for a new opportunity at that place, in a specialty, or it could benefit me in a shift or pay. I mean, it was a great thing for me as a nurse, as a professional. I gained knowledge from going from one place to the other that I couldn't have gotten if I just kind of stayed stuck in one place. And as I progressed in my career, I even decided at one point, well, maybe I need to go to Ohio. It was what worked best for my family. So I went to Ohio. But that was kind of a hassle. I had to drive 45 minutes. I had to get a new license. I had to get new credentials. It was not the easiest thing to do. So I wound up back in Kentucky. And I will say, that overall my experiences were really good. But I come to you and not speaking so much as a nurse, as a nurse family member, because my husband, when he was 40 years old, he went into the hospital. He started having symptoms. We were shopping at Walmart, started having symptoms of a heart attack. I took him across the street to the hospital that was closest, and sure enough, he was having a heart attack. But they could not treat him, and they told me, and this is the first thing that I had heard about this, they said, well, because of certificate of need, we weren't allowed to have a heart center. So you have to be transferred to the hospital in the next county. So we took him to the next county, and they put stents in, and they told us we'd be there for 2 to 3 days. He was actually there for 8 days because they kept having problems. And finally, they let us go home, and I stayed with those doctors, but called them 11 months later and said, hey, he's having symptoms of blood clots. And they said, oh, there's no way because we have him on all the right medicines. I'm like, no. So they finally agreed to see him, looked me in the eye and said, I'm telling you, he can't have blood clots because of the medicines that we have him on. But I'll send him to get tested just because you're a nurse, and I'm going to prove you wrong. I said, that's fine. Went to the other hospital because I didn't want to go back to the one where they had treated him for the heart attack. Well, sure enough, he had 3 huge blood clots because he had a blood clotting disorder, which is what had caused the heart attack in the first place. So needless to say, we did not stick with those cardiologists, and we went over the river to a different provider. And then fast forward to just this past March. So we have stuck with our providers across the river. But my parents, who live in Edgewood, so very close to the local provider, they decided to stay with their providers. And my mom was sick. And I went to the hospital, or I went to the doctors with her and said, hey, you know, something's not right with my mom. And they did testing. They figured out that she had cancer. And it was of the liver. And so on March 16th, they sent her in for paracentesis, which is just to take fluid off to give her some relief. It wasn't going to cure her, but it was going to give her relief from the discomfort. So we went in, and a couple hours later, the provider called us back and said, hey, you know, we found out that her white count, which is an indicator of infection, had doubled in 4 days. And we're on the phone with her doctor to try to get a stronger antibiotic, but we're going to go ahead and send her home. Well, I looked at my mom and she looked horrible. I'm like, wait, you're going to send her home? Have you looked at her? And they're like, yeah, they'll just call in a stronger antibiotic. She'll be fine. Well, we took her out of there, even after my, you know, like questioning, and took her straight across the river to another provider. Took us 35 minutes in traffic. Got to that ER, and within 10 minutes, they admitted my mother. The whole ER was full, but in 10 minutes, they got my mom back right away because they recognized that she was in septic shock and that she was critically ill. And it took 5 hours for them to get her stable. And they said, oh, why did that other hospital, why did they send her here? Why didn't they just take care of her there? And I said, oh no, they were sending her home. And they looked at me surprised and said, she would have died. If you would have taken her home, she would have died. I said, I know. I'm a pediatric nurse, but I recognize that she was not stable. So I don't think that I should have to go across the river, send our money across the river to take care of my mom, but I am ever so grateful that I did take her across. That gave us 57 more days with my mom. And if you've ever lost a loved one, a day, you know, people talk about one more day, one more hour. I had 57 more days because that hospital saved my mom. She would have died. Her blood pressure was barely registering when we got to that hospital across the river. And so I'm so very thankful, but I want choices in Northern Kentucky. We deserve choices in Northern Kentucky as nurses and as patients. And you shouldn't have to have a nurse in your family to recognize that your parent or your loved one is so ill that they need other care. You should be able to trust those people. And I just want options that I can trust.
Thank you very much, Ms. Dwyer. I appreciate your story. One of the things I'd like to say is that being in medicine for 40 years myself, I never set out to prove anyone wrong. My job as a physician is to make sure that I can offer my patients and provide for my patients the best care either I can give or the best care that I can get them to. So I apologize for the situation that you've had to go through, but I want you to know that is not the norm. That is not the norm of medicine. With that being said, I would ask, is there anyone on the committee who has any questions? I do believe that Senator Schickel has one. Yes, Senator Schickel.
Yeah, thank you, Mr. Chairman. I have a question and then I have a comment, if you'll indulge me. The first question I have is of Dr. Is it Schwar? Is that how you say your name?
You say it better than I do.
Well, good. Well, I'm going to ask this question only if you can promise me that you can answer it in 2 sentences.
You know, before I was a doctor, I was an actor.
Only if you can answer it in 2. This is a very
You
well.
lose.
But this is a serious matter, Doctor.
Yes, sir.
Okay. Can you describe to me any difficulties which you may have had with non-compete clauses concerning St. Elizabeth? 2 sentences.
Not with St. Elizabeth's, but with my own experience. I was with a group, and I had to sign a non-compete clause, and this was in 2004, and I had to cross the river to practice, and I came back in 2008 to practice medicine in Kentucky.
Thank you for that answer. The next thing is a comment, if I may, Mr. Chairman.
Go ahead, Senator.
Thank you. I've been in the legislature quite a while. I remember President Stein, and I can tell you that in Northern Kentucky, this issue has probably replaced the Brent Spence Bridge as the biggest issue we have. I hear about it every day from constituents, especially senior citizens. I want to thank Representative Proctor and this panel, but I see Representative Rawlings in the back too. I see a lot of constituents from Northern Kentucky, especially Boone County, that are very, very concerned about this. I want to thank you for your advocacy, because this is not an easy issue politically. Marianne, you especially know that. You're swimming upstream all the time. You don't get any PAC checks for it or anything like that. It's just all hard work. But it's work on behalf of the people of my district, and I appreciate it. Thank you.
Thank you, Senator Schickel.
Thank you,
Senator
Senator.
Berg?
Thank you, sir. Doctor, and I'm not going to pronounce it correctly, I'm sure, Dr. Schwer.
Yes, that's beautiful.
Awesome. I just got a little confused with your testimony.
Yes, ma'am.
What did your non-compete with your own group have to do with CON in the state?
It doesn't have anything to do with the CON directly. It's just another barrier.
Okay.
We have all these barriers to healthcare.
Right. And I don't want to speak out of turn, but I mean, first of all, I don't think that non-competes in medicine should be held in this state, and I don't think they do hold in this state at this point. So just a general word, I do not think that non-competes are enforceable for physicians at this point in this state. But
Well,
that has nothing to do with CON.
That I'll have to fact check that, but that's not my understanding. But the point is, I think many physicians feel trapped. They feel trapped. And I think the other thing is, physicians have workers' rights. We have rights. And they whether you're a pharmacist or a physician or a respiratory therapist, we need to have clear and transparent workings of these organizations. And I don't think we have that. I don't think we have, and you can fact check me on all of this, but we need to have that with the money that's spent by hospitals throughout the state, not just in Northern Kentucky, and also in terms of labor rights.
Thank you very much.
Thank you, sir. And I don't disagree with you. And, I mean, there's some thought that healthcare providers need to unionize at this point because the whole system is changing. So, but I just don't understand the relevancy to this discussion on CON specifically. So that was my question.
Thank you, Senator Berg. Senator Meredith, do you have a question?
No, Mr. Chair, just some comments, if I may.
Proceed.
This is my 8th year in the Senate, and folks ask me about the experience here, and I tell you, the biggest divide we have here is not political. It's urban versus rural, and I think this issue is boiling down to that. We've had a lot of people testify over the last 5 months about the impact of this on rural communities, but I haven't heard from many rural providers so far. It's been folks from the urban areas. And I guess they know that the resistance to repealing certificate of need, the strongest resistance, is going to come from rural Kentucky, and rightfully so. Suggested that certificate of need is hurting rural hospitals by limiting the number of beds. Well, in any industry, kind of the industry standard is capacity is at 80-85%. You don't add capacity until you're at 80-85%. Well, I think for Kentucky statewide, the occupancy for inpatient beds is right at 66%, somewhere in between there. Then we say, well, what happens when you have COVID? That's a once-in-a-lifetime event. So I think that's being used in this particular situation to justify, repeal of this thing, and it shouldn't be. But people have to understand that urban and rural truly are two different worlds. And with 40 years of healthcare experience, I will tell you that repeal of certificate of need will hurt rural hospitals, because it does give us a monopoly. To a lot of people, that's a nasty word. To me, it's not. It protects a market share. You folks have heard me ask, I think during 3 committee meetings so far, the dynamics behind the finances of rural hospitals. 75 to 80% of our patients are either Medicare or Medicaid. Medicaid pays about 80% of cost. Medicare pays about 80% of cost. Medicaid pays about 66% of cost. And I've asked a question of presenters that is a failed business model, so how do rural hospitals survive? They survive on the profit margin they get on a slim piece of commercial insurance that we have that we're very limited in growing. So any division of that small piece of commercial insurance puts rural hospitals at financial risk. And why this is so important to us, in most of our rural communities, our hospitals and our school systems are the equivalent of Jefferson County's Ford, UPS, GE. It's a major part of our economy. That's why we're so protective of this. But I keep hearing data driven while we want to ignore the most obvious data driven issues. The most startling statistic for me for healthcare in Kentucky is that 40% of our population is rural. Only 17% of our primary care physicians are in rural Kentucky. Why? It's not because of certificate need, it's because of payments that go to rural communities. Rural communities are discriminated against terribly. I've asked a question in numerous committee meetings of the Secretary of the Health and Family Services, our managed care organization. Why would anyone choose to practice medicine in a rural community knowing you're going to make 25 to 30% less than your urban counterparts? And their answer is, we don't know, unless they just have a passion for it, which many people do. But you shouldn't be penalized for your passion. So you can repeal certificate of need, but I guarantee it's going to have a negligible impact on the cost of health care in Kentucky. But what it will do is place tremendous economic constraints on rural hospitals that they can't currently afford. You know, coming out of COVID, more of our rural hospitals are financially distressed. And again, it's not because of certificate of need, it's because the government payers, which we have to rely on, will not pay a fair rate. So I want to quit using this as a red herring that this could possibly be the salvation for rural hospitals, because it will not be at all. And I think we have to move away from that. But again, we've had this committee meeting, I think this is our 5th meeting, and the central theme here is this is a problem in northern Kentucky. I'm sorry for that, but you folks have to understand what the unintended consequences may be of repealing this thing, and it's going to be substantial for rural communities. And I'm personally just a little bit put out with people not respecting the importance of rural health care in Kentucky. That's all, sir.
May I reply?
Thank you, Senator Meredith. No, we really have to move on. I hate to not be polite, but we have other speakers who've been sitting back there, and they need to move on. So I want to thank you all for what you presented today, and we'll have our next presenter come up, please.
Thank you.
Mr. Duke, it's great to have you here this morning. I know that you will be very, very informative. I know you and I had talked a little earlier, and you said you were going to be pretty brief, but I want to make sure that you have the time to present the things that you'd like to present. So if you would, introduce yourself to the committee and to the people listening.
Thank you, Senator Douglas and Co-Committee Chair Weber. We appreciate the opportunity to speak here today. My name's Jim Duke. I'm here on behalf of the Kentucky Ambulance Providers Association at the request of Senator Douglas to speak today on how we feel a change in the COM process would impact EMS services, specifically the deliverability of EMS care throughout the state of Kentucky. CAPA represents...
Before you get started, if I could ask you to raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
I do.
Thank you very much. Proceed.
The Kentucky Ambulance Providers Association is unique in Kentucky that we represent a vast diversity of EMS providers. In many states, you'll have a government services provider and a hospital services provider and a fire services provider. In Kentucky, we have a membership that represents all of those. So we're very diverse. So when I speak here today, I'm speaking for all types of providers. And also, this is a good opportunity to tell you all, in Kentucky, the EMS services are predominantly provided by local governments, whether that be a local city government, county government, or a private entity providing those services on behalf of that government or at their pleasure. So when you think about EMS service deliverability in Kentucky, think about the fact that service is primarily being delivered by a local government process. It's also being delivered probably at a loss because of the inherent cost of readiness that's associated, Senator Meredith, with rural EMS, where the volume may be low, but the need to be ready for a run doesn't change. You've got to factor in that cost of readiness. This is a cost that everybody has, but it bears a little harder on the rural providers. The majority of the EMS providers, and when I say providers, I'm talking about those licensed agencies that are regulated by the Kentucky Board of EMS throughout the Commonwealth to provide the care. The majority of those are in rural areas. The majority of the runs may be happening in the urban areas, but the majority of the providers are in the rural areas. I would like to use an example of Senator Douglas, one of his constituents, Jessamine County. Jessamine County EMS provides a very high quality of EMS care, probably one of the higher qualities of EMS care as far as the work that they put into delivering good quality care anywhere in the Commonwealth. They do that at a high cost to their community. Part of that cost is offset by the limited revenue that they can receive from reimbursement. If they have to compete with other providers to make that happen, it's going to drive their costs up, at which point the local citizens are going to have to pay a higher tax rate, or the quality is going to have to go down. It's one or the other. So we feel like the changes that were made with House Bill 777 2 years ago helped fix some of the problems with the EMS certificate of need issue. We feel at this point, if it's not broke, don't fix it. It's working. We feel like any changes would be a detriment to the community or through the Commonwealth as a whole, from one end to the other. Kevin Ferris and a friend of mine from Grayson County, Senator Meredith, he's worked hard to provide services there for 30 years. That's a struggle, but it's important to him to have good services in his community. So he works jointly with local government to make sure that happens. That would be at risk if we didn't have the COM process. With that, Senator Douglas, I will be open to any questions, and I promise I'll be brief with my answers.
Well, an absolutely wonderful presentation, and that's why I reached out to you, because I do think you all should have a voice in the conversation that we're having. With that, do we, Senator Meredith? Did you?
I'd like to express my appreciation to Mr. Duke. He's one of my constituents and does a great job with his ambulance service, and appreciate you being here. But just, again, you heard me talking about the urban-rural divide, which can give some kind of history on your ambulance service. How many people do you employ? How many ambulances do you run?
We do. In Ohio County, we have 6 ambulances, and there we employ about 32 people.
And it's a large county geographically.
Over 600 square miles.
So how long does it take to go one side of the county to the other?
If you started on the south end of the county, it would take you about 40 minutes to travel to the north end of the county.
So an emergency situation, the average could be about 40 minutes to respond to that emergency.
It can happen, yes, sir.
How many runs do you all do a year?
About 4,000.
4,000.
So roughly 11 a day.
Any trouble with turnover in personnel right now?
Absolutely,
yes.
Senator Meredith. It's a continual issue now, trying to find people that want to be in the healthcare field in general, and then we have to compete with other professions within the healthcare field for those workforce resources. And also, hospitals have figured out that paramedics can help them with some of their staffing shortages. So now we're competing somewhat with the hospitals for some of our what used to be traditional EMS workforce.
I appreciate you particularly mentioning that, because we've talked about unintended consequences, and every time something happens, there seems to be an unintended consequence. And certainly this personnel shortage in healthcare has impacted you folks as it has nursing homes and other rural hospitals. So appreciate you being here today. That's all I have, Mr. Chair.
Thank you, Senator Meredith. Senator Berg?
Thank you, Mr. Chairman. Thank you, sir, for being here. Thank you for the work that you do for this state. And it is extremely important work. This is off base, but I have been in discussions with pediatric surgeons in Louisville about the need for a pediatric trauma network in this state in an effort to minimize deaths in children from gunshot wounds. And this is something that I think your services play a huge, huge part of, is how do we get these children to surgeons that know how to treat them in a timely manner. So I'm just saying this because this is so important for the health of our Commonwealth. And the type of work that you do is so substantive to us at the hospitals being able to do the type of work we do. So thank you.
Thank you.
Thank you very much, Senator Burke. Representative Proctor.
Thank you, Mr. Chair. Thank you so much for what you do. I've been talking with a lot of firefighters, and it's tough, especially when you have your bad run. So I appreciate what you're doing. I appreciate what you're bringing. My question for you is, do you know how many states regulate ambulances with the certificate of need?
Very few. I currently serve as the co-chair of the American Ambulance Association's Government Affairs Committee. So I was in 3 meetings yesterday with various states over various workforce and EMS issues, and I think that the answer to that is there are not very many states that currently have an EMS certificate of need. But I'd like to add to that those states also inherently have some problems that we currently don't have in Kentucky as a result of that.
May I follow up? Because that was my next question. Is there any evidence that the ambulance services, it's 8 states that have CON. Is there any evidence in the other 42 states that the ambulance service are in danger of collapse?
Yes, there's many instances where ambulance services are threatening to collapse. I currently get an email weekly from Rob Lawrence who works toward printing out a list of services that have closed over the last week or in danger of closing, and that's happening all across the nation at this time. I don't have any, I'd like to add to that, I don't want to try to shade that one way or the other. I can't tell you if that's happening at a higher rate in the 42 states that doesn't have CON or the 8 that do. I don't have that data.
Thank you so very much, Mr. Duke, for the time and for the answers.
Thank you for the ability to speak.
Now we do have another group of people to present this morning. They simply put it under birthing center concerns. So this will be very interesting. Is there a particular order that anyone would like to come up? I think we have Elena Oak. Are you all coming together?
Yeah, we're not all talking about birthing centers, but we're sort of a group. We've coordinated.
We look forward to
time.
We look forward to hearing. Do we have enough chairs? You can always pull up more chairs. I would like for you to introduce yourselves for the committee and as well as introduce yourselves for the people who are in the audience and watching.
I'm Nancy Galvani, president of Kentucky Hospital Association.
I'm Aaron Crum, Chief Medical Officer at Pikeville Medical Center.
I'm Russ Rinaldo, the Chief Financial Officer at Owensboro Health.
I'm Elena Oak. I'm the lead physician of the laborist group at St. Elizabeth Healthcare.
Thank you all so very much for being here with us this morning. If you would, just raise your right hands. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
Yes.
Thank you very much. I'll leave it up to you, Ms. Galvani, or whoever wants to speak first.
I'm not sure why the screens aren't working.
Well, I could tell a joke in the interim, but I'm more than happy to.
You'll have to. They have a copy of it in their folders. I'll call.
Oh, okay. Well, I'll go ahead and start. So Thank you again for allowing KHA to be here, Chairman Douglas, Chairman Weber, and members of the task force. We're very pleased to be back to talk about Certificate of Need. And in our time this morning, I want to share with you very briefly the latest findings from a new report from Ascendient, which is a national consultant, which we think will provide the task force with solid facts from current research into the actual differences between Kentucky and states that do not have Certificate of Need. And we won't try to go into detail on each of the slides. Of course, I'm sorry you can't see them up here, but if they're in your packet, I can maybe talk about which slide I'm referencing.
We have them. Thank you very much.
Okay, great. But I'm simply going to hit the high points of the study. So this report updates one produced in 2019 that looked at facts on the ground, not theories, surrounding real-world effects of the Certificate of Need program. So I'm going to turn to slide 2 now in your packet. So this study compares Kentucky to the other states for current performance on cost and access to care. And based on the experiences of states that have ended the Certificate of Need program, the study also examines what the effects on cost and access would be in Kentucky if we did not have Certificate of Need. Now I'm going to turn to slide 3. The good news is that Kentucky outperforms states that do not have Certificate of Need on a number of measures, including cost to the patient and patient access. I'm going to turn to slide 5 now. That slide 5 shows that Kentucky's net price, which is the payment, not the charge, per inpatient discharge is $1,000 lower than the median of no Certificate of Need states, and that is more than 10% lower. And Kentucky also has the 10th lowest price per inpatient discharge in the United States. And while it's not on this slide, I'd like to address the RAND report. The RAND report has come out in 4 different years and consistently ranks Kentucky in the bottom of states in commercial prices. In fact, in the first report, we were the 4th lowest. Indiana, that doesn't have Certificate of Need, was the highest in the nation. I'm going to move to slide 7 now. And that is looking at how Kentucky hospitals serve a more vulnerable population. And so it's really remarkable. The fact that patients in Kentucky have a lower cost of care and better access to care is very impressive, given that our population is older, poorer, and sicker than states without Certificate of Need. And as I mentioned at the outset, the study also looks at the effect of removing Certificate of Need and what Kentuckians could expect to happen if Certificate of Need were eliminated here. Now, I'm not going to go over slide 8, but that data is there for you so you can see how Kentucky compares on a number of metrics to the states that don't have CON, as well as our neighbors in Ohio and Indiana that do not have Certificate of Need. So I'm going to move to slide 9 now. Repeal leads to urbanization. States that eliminated their Certificate of Need program saw a marked urbanization of hospitals, and rural access was affected adversely. If hospitals were distributed like physicians, which are not regulated by Certificate of Need, there would be a far fewer number of hospitals located in rural areas than there are today. I'm going to move to slide 10 now, case studies. The study provided several states as case studies, and we won't go into all of those. But notably, states that fully or partially repealed Certificate of Need for freestanding non-hospital surgery centers saw an immediate explosion in those facilities in urban, suburban, and in rural areas. And really notably, in Georgia, 7 of 9 closed hospitals had multiple surgery centers built in adjacent counties, indicating that hospitals and rural access will be harmed when these types of facilities are built, even if they are built within the region of a rural hospital, because they will cherry-pick the few commercial patients in the area and bleed the hospital dry. I'm going to move to slide 11 now, the impact of CON repeal. If Kentucky ends its Certificate of Need program, and the same trends occur here as in other states that have ended Certificate of Need, we stand to have a net loss of at least 10 hospitals. Costs will rise for patients and their insurers, resulting in increased spending of nearly $500 million more for hospital care each year. I'm going to go to slide 12 now. Kentucky can't afford to be like the no certificate of need states because Kentucky's also likely to see its per capita health spending exceed the national average by nearly 20%. I'm going to move to slide 13 now. No free market. That's important because we think there's a misconception that there's a free market in healthcare or that one would spring into existence if certificate of need were eliminated. So let's be clear. Healthcare in the United States is not provided in a free market, as you've heard Senator Meredith mention. 70 to 80% of the patients in Kentucky hospitals are on Medicare or Medicaid that pay below cost. It hasn't been provided in a free market for many decades. Like 34 other states, Kentucky maintains a Certificate of Need program to ensure access to care and safety. And unlike many of those other states, Kentucky maintains Certificate of Need for relatively few services. The Kentucky Certificate of Need program focuses primarily on a core set of facilities and services that are high cost and where sufficient utilization is needed to tie to quality outcomes. The state has established criteria to ensure sufficient need exists for these facilities and services, which is important given that taxpayer-funded government programs are the primary payers for this care. Without Certificate of Need, out-of-state entities would quickly swoop in to cherry-pick the few commercially insured patients away from hospitals for the most profitable services hospitals provide. Meanwhile, Medicare, Medicaid, and the uninsured would be left to the hospitals. Access would soon end because hospitals would be forced to close unprofitable services and some facilities could close entirely. So Kentucky's hospitals strongly urge retention of Certificate of Need and the access and safety for patients it helps to ensure. I'd like to turn to Russ Rinaldo, my colleague here from Owensboro Health, who was in Pennsylvania at the time they repealed Certificate of Need, to learn more what happened there.
Hi, I'm Russ Rinaldo. I'm the CFO at Owensboro Health, and I'm also the chair of the Hospital Technical Advisory Committee. I apologize, my slides aren't numbered, but I was in Pennsylvania when CON sunset in December of 1996, before I moved back here to Kentucky. And what I've got is some slides from a report. There was the Pennsylvania Healthcare Cost Containment Council, which is an independent state agency that reports on publicly on cost and quality data in Pennsylvania, put out a report about 10 years after the sunset of CON. And these slides are just basically what happened to hospitals in that period. If you go to the second slide in, the council members that are there, this was not a provider group. There were employers, there were insurers, there were unions, there were physicians and hospitals all made up this council. If you go to the next slide, it's a statewide total and operating margins. You can see the margins, and the fiscal year 97 was the middle of the year before CON was sunset. And you can see where the operating margins and the total margins went for acute care hospitals over the next 10 or 8 year period. It actually took, you see it go down to 1% in 98 and actually went negative in fiscal year 99. It took 8 years for hospitals to recover past the sunset of CON. And what the report did note is that you see the big jump from 04 to 05. They said 44% of that increase was earned by just 5 hospitals. So 5 rich hospitals drove that growth. It also said that the most of that jump was due to commercial payers and commercial payments. And you'll see some of that cost shifting here in some later slides. If you go to the next slide, you can see the distribution. So this shows the 3-year average operating margin distribution for general acute care hospitals for the fiscal year 95 to 97, pre-CON sunset, and then 03 to 05 when the report was done. And you can see that the hospitals that had a loss increased dramatically. The report noted that the 59 hospitals in 2005 lost money from between 2003 and 2005. 56 of those 59 were small and medium community hospitals, many in rural areas. You can also see what I mentioned in the prior slide. The largest and the most rich systems got richer. They went actually from a 4% to an 8% operating margin post-CON sunset. If you go to the next slide, these are the facilities and the numbers of facilities that changed over time. General acute care hospitals went from 206 to 177. So there was a reduction of about 29 hospitals. Psychiatric hospitals also reduced. Staff beds fell by 22%. And the reduction change on the general acute care hospitals was 3 times greater than national average over this period of time. If you look at the number of ASCs, the ambulatory surgery centers, they quadrupled. Their case growth was 842%, while the hospitals only grew at 52% over the 10-year period. The report also noted that those ASCs on a Medicaid basis only saw 3% Medicaid in their cases, while the hospitals were at 10%. So you say they took less of the worst payer. If you go to the next slide, the average age of plant. Average age of plant is a ratio that we use, and it shows how well hospitals are replacing their capital. If you have a financial trouble, you don't take your depreciation and save it and put it back into your plant and equipment. You use it for operations. And you can see Pennsylvania was about a half a year in 1995 behind the U.S. Average age of plant. But in 2005, that had grown to 2.2 years. So the plants were aging and they weren't being able to be replaced as they were pre-CON sunset. And you go look at the next slide and talk about cost shifting. So I know we had one testimony that said that there was no evidence that hospitals rely on cost shifting, called it a red herring. If you look at the inpatient discharges on this slide, if you look at Medicare from 98 was at 47%, 47.08%. They were 47.69% in 05. But if you look at the inpatient revenue percentage, it actually went down. Medicare went from 54% to 47%. So the Medicare had the same amount of discharges as a percentage, but the net revenue percentage was less. Look at commercial. Commercial is 33.3% in 98 and 31.9% of discharges in 2005. So your commercial discharges have gone down. But if you look at where the commercial is, commercial percentage of inpatient net revenue actually went up. It went from 29.91% to 34.32%. So what that means is that Medicare was paying less for the care. Your employers and your commercial insurers were paying more for less discharges. It's cost shifting. Those hospitals were in trouble. My hospital was in trouble. We had to renegotiate contracts. We had to survive, and that's how we survived. If you look at the next slide, this is the statewide net patient revenue for general acute care hospitals. Again, this is overall revenue. Medicare actually went down. Commercial actually went up from 36% to 42.5%. The report actually states that there was cost shifting that occurred, and it occurred after the CON sunset. And you want to talk about, Senator Meredith talked about unintended consequences. One of the reasons why the Medicare went down, Medicare adjusts their payments based on wages. So they look at the wages in an area compared to the national average, and they adjust the payment. So California hospitals get paid more than I do in Kentucky because they pay their people much higher wages. In 2000, before the CON sunset in Pittsburgh, the wage index for Pittsburgh was 1.0. That meant it was the national average. When in 2005, it had dropped to 0.85. So why did it drop? Because hospitals were in financial trouble. For 3 years in my own hospital, nobody got raises. There was 1 year we got a 1% bonus, but the other 2 we didn't. So wages were essentially frozen. As the nation goes up, Pittsburgh was frozen. And so what happened was that at 0.85, I started to get less from a Medicare payment for all my services. So then it became a death spiral. Medicare payments start to go down. I start to lose money. I have to cut costs. I have to reduce services. And so, when you talk about unintended consequences, that's one that not too many people would see. Only reimbursement folks that are in the detail would see and know. But that actually happened, and that was a result of the financial condition of the hospitals at that time. And then just the summary slide. I know we've had other testimony in earlier task forces that said that the charges went down at after CON. If you look at the fourth bullet point, the charge levels, the 1997 ratio of charges to cost was 215%. In 2005 in Pennsylvania was 330%. We increased charges. We increased charges in a big way. You had 20 hospitals that converted from nonprofit to for-profit status. Uncompensated care went down. That's charity and bad debt. And they noted in 2005 only 12 hospitals had rates above the 4%, and all were small hospitals and 7 were rural. And so this report is published. I can supply it, and it just shows what happened after CON sunset. And I would echo. I do have rural hospitals. We do have rural providers, and I would tell you here my opinion is nothing good happens for a rural hospital or a rural provider with the repeal of CON.
For those who are interested, I want you to know that the materials that are being presented today, since we don't have them up here for you to look at, they are available on the Legislative Research Commission website, and you simply need to look under Certificate of Need Task Force. With that being said, anyone else? Do we have?
Look, I appreciate you guys allowing me to speak today. It's my first time in a forum such as this, so thank you. Again,
we'll be polite. We'll be gentle.
Yeah. Again, I'm Aaron Crum. I'm a practicing OBGYN for 24 years, and I'm the Chief Medical Officer at Pikeville Medical Center. And just for reference, if you don't know, that's a rural medical center. We're a regional referral center, and we're the state's only level 2 ACS verified trauma center. So we have essentially every adult service available at our hospital, and that includes everything except for transplant and burn, essentially. So that's kind of where we come from. I'm here mainly to speak on freestanding birthing centers and their removal from the current CON process, which they're included in now. And the perspective comes from an employer that has over 100 advanced care practitioners of different types, PAs, APRNs, CRNAs. So I'm very comfortable with the oversight of the practice of medicine, whether it's with direct supervision or independently practiced by that type of practitioner. And so, I know you guys have heard a ton of testimony on all of the sides of this, and I don't really want to get into the things that we're not going to change each other's mind on. But I do want to talk about my thoughts on how to continue delivering safe medical care to the mothers and babies in Kentucky. And so 3 areas that I really want to address is the first is maternal choice. I think I hear that come up a lot, whether it's practice of medicine or not, and then some financial considerations that come into play. And so what I hear often is, can a mother choose where and how to have their baby? And I think the answer to that is, and why can't they choose a freestanding birthing center? And I think the answer to that is they should be able to choose. I think that one of the, in my mind though, some of the choices would be the choice between a home birth and maybe delivering at somebody else's home is an equivocal choice. And I think those choices would not be supported by the American College of OBGYNs, although they are supported by the accrediting body that's looking to come in and certify non-CON birthing centers. I think the next level of choice in that is choosing a facility that has legislated authority and licensure to provide a service, and therefore an increased obligation beyond a layperson's skill set, and that's different than the home birth choice. And I think once that choice is made, then that care delivery model becomes the practice of medicine. And I think in every way imaginable, it's practicing medicine, and that's supported by ACOG and most all of us here. The current CON process that exists has requirements for freestanding birthing centers, and they address this concern with common sense requirements that show the importance of the care provided and that uphold the standard of care. The removal of these safeguards allows the practice of medicine in a fashion that does not meet the standard of care that's expected, and in fact it's required for everyone else that's providing this same care in the state. If our hospital was placed in a situation where we were providing care for uncomplicated vertex presentation singleton pregnancies, and that's the goal of freestanding birth center care, and we couldn't provide immediate therapies such as blood products, specialized medications, administration routes of medications, anesthesia, and access to these types of things for the things that you don't expect. Uterine inversions are a good example of that. We would go on diversion. So we wouldn't be able to provide obstetrical care because we couldn't meet the standard of care. And we, would not be able to respond to the number one killer of women, which is hemorrhage, in America. So we wouldn't be able to uphold our legal and moral liability. One of the things that happens is we know where the crisis comes, and the crisis comes in areas that we're not prepared for. And I think the proposed change to allow freestanding birthing centers without the protection of standard of care, malpractice insurance, transfer agreements, but more importantly than transfer agreements is the ability to transfer patients, true availability of transport, which we really don't have. In rural areas it's very difficult to accomplish, then that is practicing medicine in a different way than the standards that are set for practitioners in a hospital doing the exact same thing. And I really don't know of any other model that allows the standard of care to be completely deviated from in medicine based on the location of service provided or of the desire of the person who's getting the care. Now, that doesn't mean that patients can't elect to deviate from portions of said care or really even have no care at all. Still a deviation, though, and it must be addressed as such. And so the standards set out must be attained, and the proposed removal from the COM process, those standards represent a deviation from standard of care, and I think a dangerous setback in the delivery of care of mothers and babies in Kentucky. So let me mention finances. And I think there's legitimate concern that everybody's protecting their pocketbook. And of course, everybody's protecting their pocketbook a little bit. But, I don't think it's true in this area. At Pikeville Medical Center, we have 7 OBGYNs. I don't know if you know, but the malpractice for an OBGYN runs $80,000 to $100,000 a year. You know what we have to pay those people. They're very difficult to find. Right now, to staff our labor hall, our recovery room, our ORs, all those things, I'm paying people 4 times what they should be being paid because I have we have about 900 nurses. I have 80 to 100 travelers in my hospital at any time. So the cost to provide this care is exorbitant. One malpractice case, one single case, wipes out about 8 to 10 years of any profit we could ever make off of our OBGYN service line. So it's very significant what a single birth injury verdict can do for us. So, the mindset that we're really doing this to get huge profits, it's just not there. But our biggest risk for poor outcomes and also our financial and legal loss isn't the high-risk population that we know about and that we're prepared for. It's the people that have normal pregnancies. So those people that have normal pregnancies, we know that there is essentially irrefutable data that your best outcome comes when you deliver at the place where you get the most appropriate care, okay? And so, in high-risk pregnancies, we're able to accomplish that because we usually have time and planning to get people to the right place. In low-risk pregnancies, we don't know that. And so the proposed model that's coming up, I think, takes away the ability to provide even the most basic life-saving interventions for mom and baby because the time really does matter. I'll end with this, and it's kind of, as I was listening, it kind of boils down to this. Why is it that the simplest thing that you can do, which is delivering a baby, and it's been happening since the beginning of time, why is that the highest liability service, one of the highest medical liability services in the nation? And that's evidenced by malpractice lawsuit payments, by settlements, and by the malpractice rates. And I'll tell you, the reason is because the outcomes are unpredictable. We don't know what's going to happen. And one of the things that we look at with this is that the opposition's point of view is that things are almost always going to be okay. And they're right. It is almost always going to be okay, no matter where a child's born or who delivers it, and because the rate of bad things is super low. I think the question is, if we're looking at per 1,000 births, my hospital does 1,000 births a year. If we're looking at negatively affecting the long-term sequela neurologically and else and otherwise of both mom and baby, we're only looking at 5 or 10 people a year. And I think the question is, do we care about those 5 or 10 people that can have devastating outcomes? My answer is that we do. So I do want to be clear that I am very comfortable with freestanding birthing centers as they currently are laid out in the COM process, which basically says do the standard of care, have the ability to get people where their best outcomes can happen if you need to. I appreciate your time.
Thank you. Thank you very much. Do you want to
I'll just going to echo. Thank you, Dr. Crum. That was outstanding. Just for those of you that I have never met before, I am the lead physician of the inpatient obstetric group at St. Elizabeth Healthcare. I have 28 years of experience of delivering babies in the Commonwealth of Kentucky, and I have delivered over 4,000 babies. I'm not anti-home birth. I'm not anti-birthing center birth. I currently provide services to patients who transfer to my hospital for a failed out-of-hospital birth. And unfortunately, in my 28 years of experience, I have seen some poor outcome related to out-of-hospital birth where you cannot get emergent services in a timely fashion, including emergency C-sections, prompt treatment of hemorrhage, as well as administration of antibiotics to prevent severe infection. These could be life-saving to both mom and baby. So I'm not going to repeat what Dr. Crum said. I do want to address the fact that some people might argue that birthing centers would decrease maternal mortality rates in the state of Kentucky. The maternal mortality rate in the state of Kentucky is not high because women give birth in a hospital setting. It is high because of our general poor state of health among our mothers in Kentucky. Diabetes, hypertension, obesity, substance use disorder. Okay, these are people that should risk out of an out-of-hospital birth setting. So just to stay on time and be respectful, I would like to say if there is any legislation on birthing centers, our recommendation to assure the safety of mothers and babies in Kentucky would be, number one, requiring the facility to be under the direction of an obstetrician physician to assure that risk assessment is followed appropriately. This is the standard in our neighboring states of Ohio, Indiana, Tennessee, West Virginia. Require that freestanding birthing centers be close to birthing hospitals in the event that a complication arises and that transport is needed to save the life of the baby or mother. Requiring that these facilities have an active written transfer agreement with the local ambulance service and the local birthing hospital so that transport can occur quickly and enhance communication between providers to improve outcomes. Follow the American Congress of OB-GYN's criteria versus the American Association of Birth Centers criteria, which are far less strict. This would also include the requirement of birthing center birth attendants would be certified nurse midwives and not certified professional midwives, as the level of medical education and clinical experience is far different between those two types of midwives. In addition, require medical malpractice of both facilities and providers. Okay, like I said, these requirements are seen in our neighboring states that have birthing centers. We would like to see these requirements be part of any bill or legislation for freestanding birth centers. The Birthing Coalition is not supportive of including these life-saving measures in the bill. Kentucky already allows freestanding birth centers. There are licensure standards for birthing centers and requirements for physician oversight and hospital transfer agreements. The CON process assures that these requirements will be planned for and met. And why would we want to weaken Kentucky's standards for the care of our mothers and babies in the Commonwealth of Kentucky? Thank you so much for your time. I'd be happy to entertain any questions anybody might have, as well as the rest of the members here.
Thank you also very much for your presentation, and actually you were pretty concise with regard to those presentations, and I want to thank you for that as well. They were very informative. Representative Burke?
Thank you, Mr. Chair. If you would allow, I'll make a very brief comment.
Go ahead.
I do want to thank all four of you, as well as the other presenters today and those that we've heard of and from over the course of the last few months. At the risk of sounding glib, I want to use a quote that's misattributed to Mark Twain. There are three types of lies: lies, darned lies, which is not his turn of phrase, and statistics. We've heard really compelling statistical presentations from both sides on this issue. And I think the truth is that complex problems deserve nuanced solutions. So when I look at the state of health in Kentucky, I'm not drawn to a drastic change, and I'm also not drawn to the status quo. I think Kentuckians deserve something in the middle. It's a time that we really look at principled and, I'll say, surgical approaches to how we make changes here. We need to look closely at our Certificate of Need program, find ways to make those principled changes that are needed. And also we need to address the statewide health plan that is driving the decisions made in the Certificate of Need program. I think that this committee, if we work together, we can find agreements that can turn into policies that will be accepted by the healthcare providers and hospitals without failing to meet our objective of making sure that healthcare is accessible in northern Kentucky, and especially also for the people in rural Kentucky. There is a way for us to do this, but it's not drastic. It's very nuanced. And so I hope that the stakeholders will come to the table and meet with us and help us make those delicate changes that are needed so that we can continue to provide good services and increase those services where they're needed. Thank you, Mr. Chair.
Thank you so very much, Representative Burke. I think we have Representative Proctor.
Thank you, Chair. I have a question for both the physicians. Are you saying that Certificate of Need is addressing safety, or is it licensing and regulation?
I'm not sure that I know exactly what you're asking. I think that the current Certificate of Need product specifically for freestanding birth centers does affect safety because it's called for. But the removing this from the certificate, the CON process, and saying this doesn't have to be a part of it, but here's what you have to be a licensed facility. I think that's where the details are that we're saying if we're going to do that, these are the things that should be in it.
Yeah, I just want to clarify. So it's not really the Certificate of Need issue. It's the licensing and
it's both.
And regulations.
It's in the Certificate of Need process currently.
Okay.
So you can have a freestanding birth center right now if you go through the CON. And the requirements are exactly what we think they should be. The proposal is to remove it from the CON process and have it be legislated. I'm going to get off what I know. Have what it takes to make it happen. Have requirements that we don't agree with, that we think are well below the standard of care. And what we're saying is, if you do decide, hey, what I would say is, I don't want you to pull it out. But two, if you do, then we'd like it to look like practicing medicine.
Thank you. Thank you, Mr. Chair.
Thank you, Dr. Crum. And I want to thank everyone on the committee, and I want to thank everyone who has presented today. I've always said I really like to move this from the emotional realm to the objective realm. We're treating people. We're treating people. We're not just treating situations. And one of the things I've often said in my practice is that people don't like it when their family members die. The other thing I've said, as Ms. Galvani said before, a lot of people don't know what they don't know until you got to do something about it. And in medicine, I just want to remind those who aren't in the medical space that's a really scary place to be. So we have to make sure that we are being empathetic to those who practice and those who provide health care in these spaces. We're not up here as a committee saying that we know what's best for everyone, which is why we're having these committee meetings. We're simply trying to gather information, and we will get that information put together, and we will at some point try to come out with the very best recommendations that we can give, not just for the Commonwealth, but we really hope it'll be a model for others to follow across our country. With that being said, any other questions? With no other questions being here, I'd like to make the announcement that the next Certificate of Need Task Force is November the 20th. It will be chaired by the great Representative Weber. And we will likely be asking for a bit of an extension so that we can then have some time to review the material and decide where we're going to go from there. With that being said, do I hear anyone propose that we close this meeting? I hear a motion to adjourn. Do I have a second? Meeting's adjourned. Thank you all very much.
Very nice job.
Thank you.
Thanks.
Nice
Hey,
job.
I don't think we've met. Yeah, Russ, great job too. You've got all the numbers. That's really good. Impressive.
Yeah, you did great.
Okay. I've seen your name. Oh, maybe I've seen your name. Oh, maybe I saw your name. Yes. Yeah, I have it in my.